Well, good evening, everyone, and welcome to this week's weekly webinar of the Independent Medical Alliance. I'm Dr. Ryan Cole, Head of Medical and Scientific Affairs at IMA, and we have a fascinating topic tonight, and I know it touches many who are listening, and it's so important. What happens when cancer treatments stop working? One of the biggest challenges in cancer care is that tumors can adapt. They can develop treatment resistance. And staying with the same strategy may not always be a good idea, especially when you're not seeing the results that you expect. And we're going to talk about a concept that may be new to some people, but it's critical for people that are facing this complex treatment issue and this decision as what do you do? So tonight we're going to talk about drug cycling and what it is, why does it matter, how can timing, sequencing, treatment strategy influence outcomes. And I'm joined by a friend, colleague, and somebody you all know, and if you're new to us, hopefully you get to know because he's done such amazing work and is such a brilliant mind, and that's my friend and colleague, Dr. Paul Marik. He's the IMA Chief Scientific Officer, and he's going to talk with me tonight about the adaptation effects of different treatments and treatment responses, why therapies need to change over time, and how his new cancer guides may help patients and their families with some of these perplexing issues to better understand their options. Dr. Marik, thanks for joining me tonight.
Thanks, Ryan. Thanks for the introduction. So let me maybe pull up my slides.
Yeah, let's do that. We'll start with your slide deck. Paul's prepared a really good presentation on drug cycling and what exactly we're talking about in cancer care. So the floor is yours, Dr. Marik.
Yeah, so the way this started actually is like most things, I got a question from one of our listeners or viewers or followers. And basically, it was a physician. He said to me, my patients seem to be doing well for the first 2 years, respond to therapy, and then suddenly their tumors get out of control and I just can't get them to respond to therapy. They become resistant. So that took me down this really interesting journey is, what can you do to prevent cancer cells from becoming resistant? And actually, there's data on this, but it's hidden. Nobody really talks about this. And so one of the things which astonished me is there's a very well-known protocol called the Matrix protocol, which all naturopathic and many oncologists know about. It's a 4-drug regimen for the treatment of glioblastoma, and that's a brain tumor. And the 4 drugs include atorvastatin, metformin, doxycycline, and mebendazole. And if you read the paper, that's what they gave the patients. But what they don't say in the paper, and it's very difficult to find, it was actually in the protocol which was never published, is that they cycled the doxycycline and mebendazole 1 month on, 1 month off. And they did that for a very specific reason, but they haven't really published about this or written about it, so nobody really knew about it. But basically, it's a very smart way of preventing resistance when they cycle 1 month on, 1 month off doxycycline and mebendazole. And those two drugs in particular, because they act on very specific pathways. And if you have constant pressure on that pathway, just by evolutionary biology, the cells will adapt and mutate so they become resistant. And so you need to relieve the pressure on those cancer cells, because if they're continuously exposed to the same metabolic pressure, they will evolve and become resistant. Many of the other drugs act on multiple different pathways, so this doesn't become that relevant. So once they become resistant to doxycycline and mebendazole, then they start developing multiple resistance. So that was really the first clue that, we were looking at the drugs individually, but the way they act together is really very important. So just to remind folks, we're suffering a cancer pandemic. This is the incidence over the last 10 years, gone up 17%. Cases and deaths, 5%. 1 in 2 men and 1 in 3 women will develop cancer in their lifetime. So this is a disease that is going to affect everyone, directly or indirectly. Nobody is going to escape this global pandemic. And this just shows the number of new cases in the US in the last 20 years. You can see it's going up and the direction is upwards. And this was before the little episode with COVID. So this is a disease that is going to affect, almost every family. And so what we need to do is recognize this is to some degree a preventable disease. So there are things that folks can do to reduce their risk of getting cancer. And this should be the number one health care agenda of public health, because like diabetes, like Alzheimer's disease, cancer is preventable. And probably the most important is processed foods, insulin resistance, metabolic syndrome. Recently, a paper in JAMA showed that women who have a high intake of processed foods are much higher risk of colorectal cancer. So this isn't just theoretical. This is really an important issue of highly processed foods, which goes together with insulin resistance and metabolic resistance. Then obviously exposure to pesticides and chemicals, which is unfortunately ubiquitous. It's very difficult to avoid. Air pollution, people who spend the whole day indoors, people that don't get no exercise, people that get no sleep, people have too much stress. So there are multiple intersecting risk factors. Many of these are avoidable, and people should really take this seriously. So here are the key interventions to reduce the risk of cancer. Stop smoking. Smoking doesn't serve any good purpose. Limit or stop alcohol. You want a healthy diet, and the Mediterranean diet is regarded as one of the best diets. You want to exercise, and you want to take care of your metabolic syndrome. And then, as we've discussed before, there are a number of supplements that reduce your risk. There was a triple randomized, double-blind, placebo-controlled study looking at 3 supplements, vitamin D, omega-3s, and D3, and basically an exercise, and showed to reduce the risk of cancer by 60%. So these supplements here, green tea extract, curcumin, D3, and omega-3s have been shown to reduce the risk of cancer. But vitamin D is really important. Most patients who develop cancer have a vitamin D level less than 20. And if you supplement with vitamin D, you reduce the risk of cancer. So this should be a number one public health intervention. So as you know, we have the metabolic approach to dealing with cancer, because we know it's a metabolic disease. and it involves dietary changes, glucose restriction, a low-carb diet, intermittent feeding, avoiding ultra-processed foods, which include juices and drinks, repurposed drugs, which are metabolic modulators, and then lifestyle changes, which we've discussed, exercise, stress, and sleep. So what we've come up with, and I don't know if anybody else has, it just popped into my head and it came out of my computer. So I don't know where it came from, but it seems like a very catchy approach. It's called the multi-axis metabolic pressure in cancer. So it makes a lot of sense, actually. So I've got to thank my computer for actually coming up with this idea. It was its idea, not mine. And basically, what you're doing is you're simultaneously targeting 5 metabolic pathways in the cancer cell. And if you do this, the cancer cell can't get energy and it dies. That's simple how it works. And so it's brilliant in its simplicity. And we've called it, or the computer called it, the multi-axis metabolic pressure in cancer. So this becomes important because there are some patients who do respond to one agent. We hear they go on a diet and take ivermectin, the tumor goes. But it seems they're the minority. The majority of people need this multi-axis approach. So as you can see, we target the Warburg effect, which is because cancer cells are dependent on glucose by metformin and berberine. We target mitochondrial function, which is oxidative phosphorylation, by doxycycline. Interesting, the antibiotic doxycycline binds to mitochondrial RNA and prevents protein synthesis in the mitochondrion. Very interesting. Mebendazole goes for the cytoskeleton. Propranolol goes for adrenergic signaling, and melatonin goes for oxidative stress and the circadian rhythm. So with these 5 used in combination, you completely whack-a-mole the cancer cell. It has no way of getting energy and surviving. And so this has become our new approach, the multi-axis metabolic pressure in cancer. And as you can see, these are all readily available, cheap drugs that have enormous safety profile. And then what you want to do is cycle. And it seems like what you want to do is have a doxycycline month and then a mebendazole month. So you have alternating pressure on the metabolism of the cancer cell. Now, it's interesting, and we'll come to this. So the question was, look at metformin and berberine. Do you give them together or do you alternate? And do you give them 1 month and the next month off? It so happens that metformin and berberine actually act synergistically together on the glucose-Warburg pathway and therefore should be given together. If you were to skip a month, then you're actually going to have a month where you don't have blockade of that glucose pathway and the cells will come back again. So that's why you need both of these in both cycles of this 8-week cycle. There you see here we have doxycycline, and here you have mebendazole. So they put differing pressures on the cancer cell. So this is the schematic. We have a doxycycline phase and a mebendazole phase. And then so this is what I was talking about, the metformin and berberine. And you can go through all the different drugs, and it seems that if you give them together continuously, you have sustained dual metabolic pressure on the cancer cells. But if you have one on and then one off, or you have one on and one off for a month, you can see what happens. It inhibits it, but they grow back again. So, initially we were just saying, take these drugs. Now we've become actually much more precise in what we're doing. It's much more elegant. It's much more based on really good science that the drugs are given in specific combinations to have this metabolic axis effect on the cancer cells. And so that's this new idea. It's called the metabolic trap. And it's quite exciting, actually. And I don't know who thought of it, but my computer did. So I have to thank I have to thank AI for coming up with such a smart thing. And that's my talk.
Well, that was excellent, Paul. And I like that you bring up the metabolic pathway of cancer. Most people don't understand. Most people think, oh, there's a mutation, there's a cancer. But it's so important to understand that the little engines of our cell that give us energy, that control so many processes, the mitochondria, and this Warburg effect and that activity within the mitochondria affect what the nucleus does. So the mitochondria go bad, and then the nucleus can develop mutations. So this kind of goes back to the mitochondria, the work of Dr. Seyfried and others, of the mitochondria being the driver of cancer. And I think for the audience, I'm going to just share a tangential anecdote. Having worked in cancer for a career, people are like, well, why didn't my cancer get cured by this treatment or that treatment? Well, you need to remember with the billions of people that there are on the planet, and you being a unique individual, every cancer, for the most part, is unique. There are a handful of cancers that are one single genetic mutation. We know how to target those, and we've seen great advances in therapy. If you go back to Greek mythology, you think of the Hydra, the big serpent with 9 heads that lived on Lake Lerna in the marshes near the entrance to the underworld. And when you would battle the Hydra, you would cut off one head and 2 heads would grow back. And so Heracles was given the mandate to go kill the Hydra, and his nephew helped him. So they figured out if you cut off one head and cauterized it, now you could focus on the next head and cauterize it. And eventually they slayed the mythical beast. And I think it's similar in cancer. We want to cut off certain cancer pathways that are good for the cancer. We want to kill those, right? And then we want to be able to get the cell back to normal, the other cells back to full normal function, as well as the immune system. So when we see, say, chemotherapy or a treatment response, you may get this happy news, hey, 30% of the tumor is gone, it's shrinking, yay, yay, yay. And then it stabilizes and then it comes back. And that's where medicine gets perplexed, is we've tried all these things. And all of a sudden, to your point, Paul, the cancer just starts taking off again. Well, that's that other head of the Hydra growing back, because you've cut off certain pathways, but ignore the fact that something different, we won't get into the whole stem cell theory of cancer tonight, or maybe we will. But the fact that there are other heads of that dragon, that serpent lurking there that we're not hitting with certain pathways or certain treatments. So hopefully that helps in terms of the understanding. So in a long-term strategy, Dr. Marik, what's the average patient looking at in terms of, obviously, I mean, you've got a great protocol here, but what's the average patient looking at in terms of how often to do this, or the rationale, how do they share this with their doctor over time to help their doctor understand, the rationale behind this?
Yeah, so you've asked some important questions. Firstly, how to get their doctor to understand their rationale. I think it's quite difficult. You'd probably need a head transplant, because most doctors do not understand this. They do not want to understand this. And if you would ask a general oncologist, what is the Warburg effect, they'd probably look at you like you've got 4 heads. And if you don't understand the Warburg effect, you don't understand cancer. It's as simple as that. But to get to the question, what I think is remarkable is no 2 patients are the same. Every patient is different. And I'm not sure if it's the biology of the tumor, if it's their genetics, or what it is. So, every patient has to be treated individually. Some patients respond dramatically to 1 or 2 drugs. The tumor goes into remission, and, they seem to be doing well. I'll give you an example. I was called by a patient who had multiple myeloma. He had multiple courses of chemotherapy. They all failed. His oncologist said, "We've got nothing to offer." So then he read the book and he tried ivermectin and mebendazole, etc. And within 4 months, his bone marrow was normal. So that was really interesting, So whereas we've had other patients who, as I said, after 2 years seem to be responding, relapse. So I think a lot has to do with the tumor biology. It has to do with the microenvironment, has to do with the patient's immune system. I think has to do with the way the patients eat, and multiple factors. So it has to be individualized. We would hope that from the beginning, patients show a response, but some patients, it's a dynamic process. Some you have to escalate the number of meds that they're on. Um, Others, you can keep them on what they are and tailor them off. So, the patients have to be monitored. That's why I think it's difficult for a patient to do this themselves. They need a clinician who can monitor their progress and can real time adapt the medications and strategy that we use.
Well, and I like that you bring that up because not only are we treating the cancer, we're treating the whole person. And in this longer term strategy and putting pressure on the cancer cells and then shifting the pressure valves, as it were, taking care of the whole person and the individual patient saying, okay, I want a healthy metabolism overall. So those lifestyle changes that you put in there, absolutely the preventative aspect, but even when you have cancer, you do want to get your blood sugars lower. You want to get your fasting insulin lower. You want to get all those things that can drive cancer into a normal range and optimize your overall health to decrease the possibility of the cancer taking off as you've described. And fasting is part of that as well. And I absolutely agree that you brought up the point that cancer loves sugar. And there's some studies that show that cancer will preferentially use sugar at 16 times the rate of a normal cell. So if you can choke off its fuel, so many of these metabolic interventions, optimizing your individual health, is so important as a choke point for some of these pathways of the cells.
So it's interesting, speaking to patients. So I do get calls from time to time that patients usually are doing badly. So I received a call, I hope she's not listening, from a dermatologist who had metastatic breast cancer. She'd been treated. Hers was obviously a somewhat slow growing, 10 years. She'd had multiple courses of chemo. She unfortunately was metastatic. And in that 10 years, nobody had spoken to her about diet. Not a single, she'd seen multiple oncologists. And I was the first person that actually explained to her the cancer lives on glucose. You got to change your diet. And that was astonishing to me that's probably is a complete failure of medical care, because the very first thing you need to do, you tell a patient with cancer, is you want to control your diet. You can't just, high processed foods, sugary foods are out. I mean, unless the goal is to feed your cancer. But
Right.
that's not what you want to do. You want to starve it. So changing diet is so fundamental. It's the very first thing a patient with cancer must do. It's not an option. It's mandatory. They have to do it, and they can do it.
It's as
There's
important as any of the medicines they'll receive. Just that aspect of changing right there is as important as any of the therapies, is changing the diet, changing the fuel source for the cancer.
Yeah, there's a book, and I think we've discussed it, by Guy Tenenbaum. He was a gentleman with metastatic prostate cancer who had not done so well with chemo and denied chemo, who then decided he was going to cure his cancer just by diet. And that's what he did. He actually started off with like a 40-day fast, which is quite difficult for people to do. But he was really completely fixated on curing his cancer with diet and diet alone. And he's gone into remission. We don't talk about cures in cancers because we don't know, but he went into remission just through changes of his diet and some supplements. So it's really the most important step.
So, in your research and opinion, Dr. Marik, over time, why do you think these pathways become resistant? What causes the cancer to develop this resistance?
Yeah, it's a good question. I think if you don't do this multi-axis pressure, which from the beginning, so I think, the computer came up with a good idea that you should start with the multi-axis pressure to begin with, so
Mhm.
you don't allow the cancer cells to escape and to develop clones of resistant cells. I
So
think that's the problem.
you're
So I
confusing the
think
cancer, yeah.
Yeah, I think what we sometimes do is we don't attack all five pathways, and so I think it's something that I've thought, which is not that difficult to do. If you look at the pathways, you look at the drugs, it's a simple thing to do. But one has to think in those terms of blocking the main five metabolic pathways. Now, it is theoretical, but I think it makes a lot of sense. And because I think in many times we were blocking three or four of the pathways, which then allowed the cancers to be fueled by the alternative pathways and develop resistance to the other pathways. So I think, we need a multi-axis, multi-targeted approach to these cells. Maybe that's why, although we don't like chemo, but many chemotherapeutic regimens use multiple drugs because they're acting on different pathways. There's CHOP and MOP, whatever, for lymphoma. Presumably, these these drugs are acting on different pathways. So
Well,
I
and
think it's
that's a great point. I mean, you bring up, the some of the standard therapies, which against many cancers are effective. The approach there is a multi-pronged approach and multiple different chemotherapeutic agents because, to your point, they are affecting different cancer pathways. Obviously, sometimes they work, sometimes they don't. So adding in some of these others can be beneficial because of that approach. It's basically like if you keep on just a frontal assault on the tumor, then the tumor, goes off to the side. So you need that flanking maneuver against those other cancer pathways from a battlefield perspective, and reevaluating the treatment. So if the patient isn't responding, then you say, okay, whoa, time out. Let's start looking at other things. And so talk about basically that role of timing and sequencing.
Yeah, so I saw a question pop up at the bottom. So there are some drugs that act on multiple pathways simultaneously. So curcumin, metformin, they act on multiple pathways, so it becomes less important to cycle. The doxy and mebendazole already act on one pathway only, and that's why they need to be cycled. Um, the other reason to circle or cycle doxy is the effect on the microbiome. Doxycycline is an antibiotic. Out of all the antibiotics, it tends to have the least effect on the microbiome, but it seems that by alternating it further protects the microbiome. I saw a question about niclosamide that just popped down at the bottom. So
Hmm.
niclosamide is a drug that does act on multiple pathways. So it does sound like a good drug. There's one very big problem with it. One very big problem. It's not absorbed.
Mm.
So that's why it's used for tapeworm, because it kills tapeworm in the GI tract, but it's not absorbed systemically. So although in test tubes and in petri dishes and animal models it kills cancer, and this is the reason you need to actually have clinical studies. It's not absorbed from the GI tract, so it becomes pretty useless as an anti-cancer drug. They are working on ways to improve its bioavailability and different formulations, but niclosamide by itself is not very good.
Well, and
I see.
you brought up an important point there as well, and that's the microbiome. And we need to remember that about 70 to 80% of our immune system is based in the GI tract, in the gut. And so much of the training, the responses, the signals come from our bacteria that say to the immune system, we need to rev up this cell type or that cell type. And so if the microbiome isn't healthy, and there's some studies that show if your bifidobacteria, which is one of your friendlies, is low, then the immune system becomes sluggish and can't do what it needs to do. Oftentimes, most of the response in cancer in this pulsing therapy or sequence therapy that you're describing, this you can throw all these things at it, but if the gut isn't healthy, then the cells that you need to respond aren't going to be there at the number or the rate they need to be. And so optimizing the diet and optimizing gut health is part of that, critically important pathway. And so, the so much of our processed food diet has so many toxins and poisons that do affect that healthy balance of the microbiome. So eating closer to nature and whole foods is important, and avoiding, we'll talk about it later, but glyphosate, et cetera, things like that in your foods, those can alter your gut microbiome, can alter all these sequences in the world. Don't matter if you're not taking care of you in general in terms of your overall diet and health.
Yeah, I mean, a healthy gut is a healthy person. It's really important that one's microbiome, you look after it. There was a very interesting paper recently that showed that in patients with colorectal cancer, their bad bacteria get infected by a bacteriophage, which was associated with colorectal cancer. So, these bad bacteria may then become sources of these viruses, which then infect them, which cause colorectal cancer. So having a healthy microbiome is really important. And it goes back to what we said at the beginning, a healthy diet. If it looks like food, it's food. And
Right.
most food has got fiber and all the requirements. But if it comes out of a box or a wrapper, it's not real food. It's highly processed. It has no fiber, and it's going to mess up your flora.
Right.
So, we really need to, it's really important.
Yeah, and it gets back to that basic level of what are the machines inside the cell doing? And if you're giving bad fuel, you're gumming up the engine. And so making sure those mitochondria are healthy and basically trying to poison off the cancer's metabolic pathway, that's so important. How does this affect the patient, say, who does go into remission? Should they consider sequencing or pulsing over time? Or should they just focus on overall physical and dietary health?
Yeah, so it's a good question. I think people who get cancer, they need to reflect on their lifestyle, their eating habits, their sleeping habits, their exercise habits, their stress levels, and this should be a life-changing experience.
Sure. And
I mean,
and yeah, go ahead, keep going. Sorry.
and then obviously in terms of repurposed drugs, we think, as far as we know, they need them for the rest of their life, but they do not require the same intensity that was required to get them into remission.
Sure.
So once they're in remission, they can cut back, but there still are likely dormant cancer cells. These are really odd things. So these are cancer cells that become dormant, and they kind of stay dormant, but can be reactivated. And so Jane McClelland, who wrote the book How to Kill Cancer, How to Starve Cancer, that's exactly what happened to her. So she had cancer, she treated herself, the cancer went away, she stopped her medications, and then unfortunately she had a recurrence. So I think it was a lesson for everyone. Once you've had cancer, it's a diagnosis you carry for life, but you can cut back on the intensity of the nutraceuticals and repurposed drugs.
Okay. And you hit on two important points there. You reemphasize rest, which I couldn't endorse that enough. Normalizing sleep cycles and the circadian rhythm of the body, because that allows the immune system to function properly. The less you sleep, the higher your cortisol, the less balanced your immune response is. And another thing I think sometimes we don't address in medicine enough is light as therapy, and that the sunshine is your friend, setting your biological clock with morning light, setting your melatonin cycles with morning light, as well as your vitamin D levels. Obviously, in the times of year we can make our own vitamin D, getting out in those helpful rays just enough to be able to keep the immune system and your vitamin D levels normal. The effect of light on the mitochondria is so critical, and especially your body getting that near infrared light in the morning. Most people don't know that, they hear the word melatonin, they think about sleep, but your mitochondria are responsible for your intracellular melatonin, the most powerful antioxidant within the cell. And so being out in the light helps your mitochondria function better. And getting that morning light and setting that body clock is important, not just for the reason of sleep, but also for the reason of cellular function. And so there's just so many little tweaks each of us can do in our lifestyles, not only as a preventative, but also in a treatment strategy, I would conjecture.
Yeah, we spend too much of our time indoors with artificial light, which doesn't, has no infrared light. So as you said, we are depleted of infrared, and infrared is what we need, as you say, to power the mitochondria. So, I think, to go outside for a 10 or 15-minute walk, serves multiple purposes. You get off your butt, you walk, you get some exercise, you get some sun. You don't need to be spend 3 hours in the sun, be obsessive, but I mean, just to get outside, it's a very healthy lifestyle
Yeah,
rather
and
than
most people have no problem, taking some supplements or taking a therapy, but that's one of the easiest therapies that's accessible for free is the sunshine, no matter where you are. And yeah, there are different light intensities based on your latitude, but at the same time, there are things we can do that are free and simple that are massively beneficial to the overall body function.
yeah, one thing people should avoid are tanning beds because they increase your risk of melanoma so like astronomically, just because of the very intense UV radiation. So you want to go outdoors with natural sun and natural wind and grounding, and do what the body was meant to do. We weren't meant to lie in suntan beds.
Well, I like that you bring up grounding as well. I mean, some people know what it is, some people don't. Can you hit on that real quick? Because I think it is synergistic with some of these pathways you've talked about.
Yeah, well, I'm not an expert in it, but you want to make contact with the ground. You don't want to, when you're walking outside, have boots that are like 6-inch heels. You want to be as close to the ground as you can, if possibly barefoot. And there's you probably understand it better than I do, but
Okay.
you're making electrical contact with the earth, and
Yes.
it does have a grounding effect on the human body. You
It,
probably understand it better than I
okay,
do.
I'll hit on it for just a few seconds here. So basically, if you don't touch the earth with your feet or your hands or whatever, touching the earth, we are electrical beings. So we build up a static charge over the day with all our artificial synthetic soles of our shoes, et cetera, et cetera. And when you build up that static charge, the cells themselves become stickier and like to stick together. Well, you want your immune cells, your blood cells, et cetera, to flow. They have something called a zeta potential. So you want to basically discharge that built up static charge. When you shuffle your feet and touch a light switch and that little shock, basically by standing on the earth, you're discharging that built up charge into the earth. Why does that matter? Well, because it changes how cells communicate with each other, and it changes a lot of the immune function. And some people will say, well, I live way north and it's, 2 feet of snow. I can't stand barefoot on the earth. You know what you can do is you can take a stick, wrap it with a copper wire up to your palm, even inside your glove, go stick that stick on the earth, and through that copper wire, you're going to discharge your built up static charge right back into the earth, and your immune cells will say, oh, thank you. I was getting too sticky and too plugged up. Now I can go do my job. And so that's kind of a layman's perspective on grounding as just another adjunct thing one can do to optimize physiologic function.
So can I ask you a question? And I saw
Please.
when there was a question, because I've seen these being advertised, and I'm not sure if it's a commercial gimmick or not, is having grounding sheets on your bed.
Okay, there are two approaches to this. So you have to make sure your house is wired correctly, number one, because there's something called dirty grounding, and that's where within the wires of your house you may end up with extra static signals if your house isn't grounded well. So the grounding outlet here in America is that third little prong, and I sleep with a grounding pillowcase, and I travel with it because oftentimes when we're at all these conferences, we don't get enough time to, go outside and stand barefoot in the hotel courtyard or whatever. But the ideal is to have a sheet or a pillowcase, and they have a long wire on them, and to just drill a copper post into the ground, drill a hole through your floor, and just put that post into the ground. Now you're not dealing with your house's electrical interference per se, but you can directly, now you're directly contacting your body to a wire that's going directly into the earth and discharging your static charge into the ground. I found that when I did it, I started a couple of years ago, my sleep was much deeper. And there's a whole movie on it, a documentary on it. I would recommend it. I think the literature on it is sparse, but it's growing. But the function of the immune system is what it seems to be altering in a beneficial way.
It's a really interesting idea, Ryan.
Yeah. So
You, you
and
can
there,
get you can get a new job. You can go around grounding people's beds.
well, and you know what else you can do? I mean, just from a simple point of view, interestingly, is you can there are kits you can buy that are really inexpensive that are copper rivets, and you basically drill a hole in the bottom of your shoe, and you pound the rivet flat, and now that copper rivet is touching your foot, and the moisture in your foot and your sock. Now you're literally walking around grounded a lot more of the time than you would be otherwise. So this is just one adjunct to all these little sequential things you can do to optimize immune function. So I think maybe we'll do a future webinar on this and just kind of as a side topic altogether, because you've done so much work on this pulsing sequencing. This is such a I think a groundbreaking way to think of cancer and those different heads of the dragon. What should patients be asking their doctor when the treatments they're on do stop working? Obviously, a lot of patients want some guidance, and you've put some wonderful guidance forth here. What should they ask their doctor, or should they find another doctor? I mean, there's a lot of good docs out there, and all of our knowledge is hopefully growing. But what should they ask their doctor when their treatment starts to fail?
Yeah, it's a good question. They should have a conversation with their physician or doctor regarding repurposed drugs, nutraceuticals, uh, metabolic therapy. And if the doctor's not open to a discussion, a reasonable discussion, because, you know, we have nothing against conventional chemotherapy, in lower doses. And it can, what we recommend can be given adjunctively. What we would really recommend is what's called metronomic dosing, which is much lower dose. But there's no reason that the traditional oncologist can't work together with an integrative physician. But
Absolutely.
if the physician's not willing to engage with the patient on this topic, the patient needs to find a new doctor that he can talk to.
Yeah, the
I think the
patient needs
days are gone where physicians dictate therapy and patients passively accept whatever they're told. Patients have to be involved. It's a partnership that's really important.
No doubt. And the patient needs to think strategically about their own care and be engaged in their care and be willing to ask those questions when things change, things aren't working. And I think you bring up a great point with your presentation and your slides is, wait a minute, if this isn't working, it doesn't mean there's nothing you can do. There are plenty of other things that can be done. And one may not work, two may not work, but the third or the fourth may. And I think looking outside the box and thinking, okay, how can I adjunctively help the therapy that I am on, and or if the therapy I'm on isn't working, what other things are out there with a biological basis? And I like that you put that forward, Dr. Marik, that they can say, okay, I'm not giving up. I'm going to try something else.
Yeah, I think that's the point. You can't give up hope because hope is really important. So patients have to have the right attitude, and there are a multitude of things that we can try. Now, what's really important is it needs to be science-based and there needs to be a biological feasibility because unfortunately there are interventions out there that are completely unscientific and potentially dangerous. So patients need to be aware, buyer beware. But I think there's enough information out there that, patients need to take control. I think the days where they were passive passengers and did exactly what the physician said are done. Patients need to take ownership and need to be involved. And I think that's an important key. And that in and of itself will help them heal because they're part of the healing process. They have to have the right mind, they have to have the right attitude, and they need to have stress reduction, sleep, exercise, all of those things that they need to own.
Absolutely. And I like that you bring up that mindset because that affects the immune system as well. It's not a fun thing to go through. I have a close family member just recently diagnosed, surgery coming up Monday, and the double mastectomy, it's going to be a long procedure. Thankfully, the horse isn't out of the barn, but the metabolic lifestyle changes have already started at the moment the diagnosis hit. And so the patient not giving up hope, keeping that positive mindset will affect how the immune system functions as well. That's such an important aspect of these treatments that you put forward. Dr. Marik, you've incessantly researched this and put together a new guide for patients. You want to tell me about your work on that?
Yeah, so we have a bunch of new guides. The one is on the recycling and the drug resistance. The other one is the metabolic trap that I've spoken about. And then obviously our approach to cancer gets updated. We must be on our 24th or 25th revision. As new information comes about, we adapt it. So, which is the nice thing about posting it online rather than a book because a book is static, it doesn't grow, and it's usually outdated very quickly. So being able to post things online allows us to update them very quickly.
And you'll be speaking on this at our annual conference upcoming really soon here, won't you?
Yeah, so I'll be talking about mainly prevention because you know what's more important than preventing a fatal disease? And as we said, there are things that people can do, proactively can do, depending on their risk. They need to risk stratify them. For example, if you have a first degree relative in your family who's had prostate cancer, the risk of you getting cancer is threefold increased. If they're two first degree relatives, it's like sixfold. If you're African American, it's like 15-fold. So you are at, you can risk stratify yourself according to your risk of breast cancer or prostate cancer or colorectal cancer. And you can be proactive to take measures to limit those cancers developing.
Yeah,
It's
I like the quote, life or genetics loads the gun, but lifestyle pulls the trigger.
Yes.
And so many of these things that you will be addressing, and I know it's going to be a great talk. I'm looking forward to just, those updates. And I like that you bring up the fact that there are so many things that we can each do on a daily basis that will not only prevent, but treat. And I like that you bring up that this is an evolving field. The knowledge is always moving forward. So to keep it fresh, which you've done, and keep people on the cutting edge of things to look at. Well, I've noticed that Kelly's popped on to my screen here, so I know we're going to have some fantastic questions from the audience, and we'll get to as many as we can. So I'm going to hand it over to Kelly and fire away, Kelly.
Oh, that's
So
great.
Ryan,
We could have a whole webinar just on questions, Paul and Ryan. So, Paul, were you going to say something?
yeah, so you learn something every day. So I learned something 2 hours ago, which is really important. Someone asked me about childhood cancers, which are very different from adults. But then I asked myself, do these cancers demonstrate the Warburg effect? Because if they do, then they are amenable to metabolic manipulation. And the interesting thing is about a half of them have a very high degree of Warburg effect, which people don't take into account. So I have a table now of childhood cancers and the Warburg effect. And if they are high Warburg cancers, then you want to treat them with one of those axis modulators, which is not done in standard therapy. We're not saying ignore what the oncologist does. We say add this on top.
Absolutely.
Okay, so I'm going to go ahead and jump in. There are so many questions. I'll try to get through some of these. Amy asked, are there any unique strategies for leukemia, specifically CML, in young women who has control on sprite cell, but very much wants to start a family? Any tips on that?
Yeah, that's a good question. Everything's going to respond to a degree to metabolic therapy because your white blood cells, the ones that are the cancerous cells, they still have a metabolism as well. So altering the cancerous metabolism is still critically important. The leukemias and lymphomas tend to act differently than, say, the solid cancers of organ, breast, pancreas, colon, etc. So, Paul, what do you think on that one?
Yeah, so CML is one of the few diseases, if I'm not mistaken, that has a specific mutation. This has the Philadelphia chromosome,
Correct.
and
Correct.
it codes a specific protein for which there is a specific treatment. So, this is one of those cancers that the patient should be followed by an oncologist. But, and I think this is in our guide as well, in our approach to cancer, it doesn't mean that you shouldn't at the same time do the anti-Warburg, anti-lipid, anti-stress pathway treatment. So that makes it even more powerful. There's no question that our approach is very much synergistic with certain chemos and radiotherapy. So what I would do is I would advise her to look at our guide to repurposed drugs, and there is a section there on, if I recall well, on CML. Obviously,
We're going to actually pull the resource hub up in a bit, and I can point people to it, but the team will put that and post that in the chat. But there's so much great information, and actually, our tech team has really done a good job leveraging AI to do better search. So put these topics in our search bar too. But the whole hub includes all of these documents. The ones that Dr. Marik talked about tonight have all been updated on the site. Wanted to make sure they're up and available tonight, for the discussion.
Ellie, did you say she was pregnant or wanted to get pregnant?
No, she wants to start a family. So I think it's just thinking about that in the near future.
Yeah, so obviously one has to be very careful about taking drugs when one's pregnant.
Yeah.
That's another issue.
Well, and this may be in this new cycling document. I presume it is, Paul, but someone asked, is there a way that you can publish the references for the doxycycline mebendazole protocol? So I'm presuming you've got references in there that led to your point of view, but there's probably not a reference for that. Your review brings it all together.
It was mysterious because There are review papers that talk about it, but it was a hidden gem. I never knew until recently about the cycling, and I don't know why. Even the people who wrote the protocol didn't talk about cycling. So you just got to trust me. But the best thing is to do a search. Do a search on cycling, doxycycline, mebendazole, and she'll come up with something
Yeah, and
because it's
real quick, remember your body cycles every day. You don't have high insulin all day, high cortisol all day. Your body knows that it goes through a cycle of a lot of signals all day long. It's called your diurnal variation.
Mhm.
So same thing when you're treating something that's off cycle, you're trying to cycle something to match the most beneficial timing of treating human physiology.
so
I
what
heard
Ryan
both of you
suggests.
tonight refer to cycling and pulsing. So cycling to me would be on and off, or pulsing might be at a
Right.
higher dose and a lower dose. Could you comment on that?
So
Did
can
I
I
get that
just say
correctly?
something? Ryan has just mentioned something which I just remembered, which is fascinating. So ACE inhibitors are pretty good drugs. They're used for treatment of blood pressure and heart failure. There's overwhelming evidence that they work much better when taken at night,
Hmm.
just because of this chronorhythm that we have. And so
That
most
would
people,
include propranolol. Um,
no, no.
okay.
So it's yeah, it's things like ramipril and
Mm.
uh, Vasotec and Captopril, a whole bunch of ACE inhibitors. One of the most common antihypertensive and most effective. But the remarkable thing is because of these diurnal variations, it works much more effective if taken at night. So, most doctors don't know that.
Well, and
Yeah.
I brought this up because someone had Laura asked a question. Would you please discuss why propranolol, sorry, I'm
Mhm.
pronouncing this horribly, is essential in the mix because it's such a fatiguing medication?
Yeah, so it's low dose. We use 20 milligrams low dose twice a day because it has to be propranolol, which is a non-selective beta blocker, because it blocks the stress response. Basically, because particularly if someone is highly stressed. So that you can take it all the time, or you can take it during periods of stress. For example, surgery or a stressful uh, life event, but it blocks the adrenergic receptors, which are on tumor cells and make them grow. So there's really good data. There's very good data on women on propranolol and breast cancer. They do significantly better on propranolol. And it's not high dose, it's a low dose just to try and attenuate the stress response. That's what it is. So, if you're not really good at meditation and relaxing and just chilling out, this is a chilling out alternative because the stress response is very profound.
And
Well,
another
and,
one I know
and in your approach to repurpose drugs document, you do break out the different therapies that are strongest for particular forms of cancer, so people can look for that as well.
Yeah.
Yeah, and Paul in some of his other folios has brought up low-dose naltrexone, which has a similar effect.
Mhm.
And
There have been,
Kelly, I just have to jump for a second. There's someone
okay,
ringing my doorbell.
okay.
All right, fire the next question
All
at
right, let
me
me try
there.
you, Dr. Cole.
Okay, fair enough.
One a question, and we've gotten this on other webinars. I think it's important to bring up. What are the hazards, Bob asked us, of drug interactions with herbal remedies and diet interventions?
Fantastic question.
Yeah.
So remember, herbal medications are medicines.
Mhm.
And so your body, especially your liver and what we know is your cytochrome P450 oxidase system and all the little subgenes of that same system, they are responsible for the toxic clearing of anything you consume. So taking a bunch of medicines and herbs on top of it, you have to be careful. You have to monitor your liver enzymes, make sure you're not causing harm in that regard. So herbs are medicines. So if you're going to add an herb on, make sure you're monitoring yourself carefully. And just because a little bit is good doesn't mean a lot is better. And many of those do have strong pathophysiologic effects on the body. So
Mhm.
being selective about what you do, uh, how much you do is so important to not overdose on those herbs. And another thing too, grapefruit juice will augment the effect of so many medicines because it blocks that detox CYP450 pathway. And then you can actually end up with higher serum levels of drugs or the metabolites of these herbs that do affect your body.
And Dr. Marik, we do try to mention any contraindications or any, as in the different documents that you provide as well, but that's a good just overall warning as it relates to the herbal
Yeah, so
medication.
you have to be aware of drug interactions.
Mhm.
One of the more dangerous ones is, Ryan probably likes methylene blue, particularly with infrared. The problem is if you're taking a tricyclic or SSRI, you can have a terrible interaction.
Mm.
So one has to be careful of the drug interactions. When there is a potential drug interaction, we do list it in the monographs.
Yep.
I think that's one of the more dangerous ones.
Yeah, and I'm very careful with methylene blue. I use it on rare occasion, but it can also alter the microbiome. It's the precursor to hydroxychloroquine. So, again, another topic for another time. But yeah, be very careful with that one, even though it's all over the internet with influencers and whatnot. Pros, cons, Goldilocks effect, and just enough, not too much, and not too often.
I know we're at the top of the hour, but I've got a couple related questions we'll ask together because we get a lot of questions. One here was if would this protocol work for a person who had surgery and is clear? And you talked a little bit about remission. So do you want to state that again, Paul? I heard you say yes, in low doses, you'll probably need to be taking some of these medications the rest of your life for protection. Is that true?
So if someone, we have what happens if you have cancer and you have surgery is surgery will cause the cancer cells to break off and circulate in the bloodstream and possibly cause metastases. So surgery per se can result in metastatic spread. So we have a protocol, which I think is in the Cancer Hub, that patients should adopt before surgery. So, 2
We have
weeks.
it pre-operative if you search it.
Yeah, pre-operatively, they should take it.
Mm.
Now, the problem is a cancer cell's tiny, it's minuscule. You can't see it. It has to grow, 10 to the 6, I think, or 10 to the 9 before it's a centimeter. So the problem is these little cancer cells can disseminate and can take 4 or 5 years until they reach the size of a
Mhm.
clinically detectable tumor. So that's why if once you've had surgery, you may appear to be in remission and be cured, but I would assume you still have dormant cancer cells, and I would take some kind of anti-cancer therapy. Obviously, the intensity wouldn't be the same as if you actually had cancer, but I would I wouldn't assume that it's all been removed, and I would take a few anti-cancer drugs just probably for life because
Okay. Now, Diana
it's
had asked that direct question too, and then said, would you also apply to skin cancers that are removed with MOHS surgery?
yes.
No,
So
usually I can speak to that because that's my
Mhm.
subspecialty. Basal cell and squamous cell cancers, more often than not, once they're out, they're out. We've looked at the margins, we look at the lymphatic vessels, make sure
Okay.
there's nothing in those. So different for skin cancers, not melanoma, that's a different story. But for those other just common skin
Okay.
cancers, yeah, I would focus on lifestyle, like Dr. Marik has brought up.
And I know we've brought this question up before, but we always get it, I know, into support, which is many people are very concerned about biopsies, and that if they get a biopsy, that breaks the seal of, the particular tumor, and that could cause it to spread throughout the system. What are your doctor's opinion on that?
I have varying opinion on this. I've seen a lot of that as well. There's something called intracellular adhesion molecules, ICAMs, which
Mhm.
basically is one cancer cell holding onto the one next to it, holding onto the next, et cetera, holding itself together in a ball. Once a tumor starts to lose that adhesion, that glue to each other, then that possibility, does increase slightly. If a tumor hasn't lost that ability to hold on to its neighbor yet, then the chance of that is low. So the literature is very sparse on this. I mean, there's a lot of fear out there of that, but at the same time, how are you going to treat a cancer if you don't know what you're treating? So it's a two-edged sword.
Yeah, so I think with surgery, there's good evidence that it can cause dissemination of cancer cells. With biopsies, it's possible, but you need a biopsy. There's no question of doubt. So, I was reading a case record of a patient who was being treated for a pulled muscle, and this muscle grew, and they were doing all kinds of bizarre things. And then they eventually did a biopsy, and it was a sarcoma. So there's no question, if you have a lump or a bump, you need a biopsy. But the preoperative protocol we have, you can use that pre-biopsy as well. And although the risk is probably a lot less, at least it gives the person some peace of mind that they're doing something, and it will reduce the risk of metastatic spread.
Well, maybe what we'll do is if you can both hang on for a minute, Libby, if you can pull up the website, the Cancer Resource Hub. I just want to make sure that the link we have been posting in the chat as well. But if we were to scroll down on this, you can see how we have a whole area of repurposed and adjunctive therapies here on the left. And that top document, Approach to Repurposed Drugs, Dr. Marik has referenced a number of times. It breaks down the key therapies for different forms of cancer. We have so much good information that's really critical on nutrition and diet that Dr. Cole and Dr. Marik have addressed, and lots of areas of prevention and risk reduction. And if we go further down, we've got our deeper research for those that really want to get in the research. Then we've got the full cancer care monograph. If we scroll down a little bit further. And as Paul said, although the book is available on Amazon, which is helpful because it's printed and it's 1,400 references, about 200 pages, it's always the most up to date here on our website, and it's always provided free. So a lot of amazing resources. Use our search and hopefully find anything that you've got particular interest in. So just want to make sure people know that that's available. And we are only able to provide all this great resources and work because of folks that are helping us support and give to the organization. So thank you very much. And then I was going to see Dr. Cole or Dr. Marik, anything before we wrap up on that? I was going to have Dr. Cole talk a little bit about the MAPS conference.
Any comments? I'll throw to you, Dr. Marik. I just want to I want to thank Dr. Marik for his just dedicated research to this field and just the wonderful amount of knowledge that he's brought forth. And his guides are there. You don't have to do everything, but there's so many things you can do. And so, like he said earlier, and I agree, don't give up hope. There are a lot of things you can do. And just want to thank Dr. Marik for his wonderful amount of work that he's put into this.
Okay, thanks, Paul.
Thank you, Kelly. Hey, Kelly, can I ask you a question? Were my slides,
of course you can.
Were my slides not changing?
At first they weren't. I think you were just still talking at the title slide, so we were worried they won't, but then they did change. So that's why I stopped texting you.
They worked. They were all there.
They're all there. So thank you. And for anyone we got a few questions that for people, all the slides will be posted with the webcast. We usually post it tomorrow on the homepage, midday US time. And I like your slides were very well done, Paul. I thought they were very clean and easy to understand, even for the layperson like myself.
Yeah, well, I have some assistants.
Yes.
Yes, they're really very artistically inclined, so they did a really good job.
The whole team behind Paul. All right. Okay, well, Ryan, I thought we'd talk real quick. I know we're running kind of tight on time here, but you're just at the MAPS conference. Olivia's going to pull up a couple pictures here that we can cycle through and just tell us a little bit. You and Dr. Elizabeth Mumper, another senior fellow in pediatric education, supposed to speak at the conference.
Yeah, this was an amazing conference. So it's the Medical Academy for Pediatrics and Special Needs, and they focus on autism, ADHD, PANS, metabolic issues, treatment issues, and it was a well-attended conference. And what I was encouraged by was so many pediatricians that are perhaps new to the thinking outside the box field were there for the first time, and it was a wonderful conference and so much information. It was drinking from a fire hose, but again, it goes to not giving up hope. There's so many therapies that are ignored, so many metabolic issues like Dr. Marik was talking about tonight, just giving hope to these young children with these challenging conditions, and so many just positive stories of improvements and the rare cures and whatnot. And I was privileged to be there with Dr. Mumper, one of our senior fellows, who is one of the leaders of MAPS, as well as our pediatric fellow, Dr. Catherine Welch. And so it was a wealth of information, a wealth of wonderful people, and just a great opportunity. I look forward to next year's annual conference. They do such good work.
It's a really nice partnership that we have with MAPS, because they specialize in an area that complements our work so well. So it's a great resource for people with questions on pediatric care.
And I spoke on glyphosate, and we'll do a future webinar.
Yes, everyone's dying for a webinar on that, Dr. Cole, for sure. That's going to be an important one. We were talking about that in our editorial meeting today. So, all right. Well, next week we have Dr. Cole back. So I hope we're not wearing Dr. Cole out.
Not at all.
But he's going to be talking with Janja Kellick. We can pull that slide up. And he has written a book on his 2 decades of work on investigating and organ harvesting. Just a very difficult topic. Dr. Verone actually wrote the foreword to his book. We're going to talk about that with him, learn a little bit about that topic, and actually Jan's going to be at our conference going and doing a more detailed lecture on all of his findings in Dallas too. So if people want to see us in person and join us, we have that conference coming up too that we'll get into. And then for our Parents First project is a really critical initiative. Many people may be following just the ups and downs of this crazy legal case on ACIP committee, which was supposed to be happening today and tomorrow, and that's put on pause right now. So more news when we have it. But what's a parent to know now? It's very confusing as it relates to what's going on with ACIP and the CDC. What do they recommend versus my state or the American Association of Pediatrics? It's just creating a huge confusion base. Well, IMA is trying to build on the good work that we've done and use our bench of pediatricians and medical and scientific experts to help us create more parents first resources, so parents really can have trusted place that they can get all this information. And we also, should we be able to get the financial support, would love to develop additional resources and educational resources for pediatricians. So we're so encouraged that MAPS is growing, but there's so much more work to be on educating on the risk of vaccines and the whole schedule. So we're looking to do that. And we've had some amazing donors that have joined us and help us create a match fund. So for every dollar it equals two, up to $250,000. So I appreciate any support or sharing that with others in your network. Then the next thing we always have new guide tools and guides. This is a great one that Dr. Christina Carmen, Senior Fellow Nutrition, helped put together. This is a nice complement to the webinar we did with Dr. Verone and Dr. Mumper. Dr. Verone published a recent scientific paper on therapies for measles treatment. Yes, there's actually treatment for measles. And they really had a great discussion on not only measles treatment for children, but for adults too. So that's a really great resource. So this is another integrative approach tool that complements that good work that was already done. And then the next is, if you want to dive deeper, we should mention the other topic, building off of Paul's lecture at the conference. We actually are going to have 2 oncologists, Dr. Ray Page and Jamie Walensko, who is one of our senior fellows and integrative oncologist. And they're going to follow Paul's updated lecture on all the scientific reviews and much of the great work that he's doing with case reviews from their frontline patients, and talk about how they're applying it, how they look at some traditional treatment and layer on the integrative forms and alternate approaches. So I think that'll be a nice complement to build on top of that. And again, you can get your conference tickets at imahealth.org/conference. And so please look at that. And if you have any physicians that are in your network that would be interested in attending, please send it. We actually have full CME credits for that. So that's a big benefit for our professionals in the audience. And then as we close tonight, I wanted to share a clip of one of our senior fellows, Dr. Molly James. And we asked her to talk about what the injustices she experienced as it relates to COVID. We are partnering with other organizations, including Brownstone and Health Freedom Defense Fund, on a COVID justice resolution. And it may seem that that's of our past, but I know many of our following want to make sure that this never happens again. So we want to create a call to action that we can use with senators and a number of signatures. Many probably have already signed this, but we'll go ahead and put that up. But Dr. James has a terrific overview that we want to share with you on what she experienced and why this can't happen again. So thank you, doctors.
I'm Dr. Molly James. I am a senior fellow in general surgery. When COVID hit, I was in the ICU working in St. Louis and New York City. I saw some terrible atrocities. Families were separated from their loved ones who were dying. Physicians triaged patients based on their vaccination status instead of their clinical condition. Once I left the ICU and was treating patients in our clinic, every single day, we ran into patients who could not get their prescriptions filled, who were denied care at emergency departments, who were told there's nothing I can do for you and sent home. Over and over, we saw this, and we fought with pharmacists to try to get medication into the hands of those patients. Not only did our patients pay the price during COVID, but my colleagues and I did as well. I lost my career in hospital medicine after 20 years. I've now opened my own clinic, so it's great. But the other thing, in the aftermath of all of this, the state medical boards began targeting doctors who had great outcomes based on politically motivated complaints, organizations who taught people how to make complaints to the medical boards. Medical organizations also targeted us. I was subject of a censure by the American College of Surgeons for my misinformation. And when I looked at their own website and the information they were doling out, it was based on CNN reports and magazines. I pointed that out to them. The concerning thing is, this can happen again. We need all of you to go to covidjustice.org and sign the resolution so the people who created these offenses are held accountable and this never happens again.